So, contrary to what some people in South Africa seem to think, I don't actually have any conflicts of interest really to declare. I don't have any Bill Gates grants relating to 5G, and I don't have anything else that will really be of help. But so I don't have any conflicts that will stop me giving this talk. What I'm going to do in this talk is just outline the problem. I'm speaking to a very experienced audience, so I'm not going to dwell long on the issues, but there are some students and others who are on the call, and so going to spend just a couple of slides looking at the problem that we've got. I'm then going to talk a little bit about what I think is the real problem that we're facing, which rather than just carbapenem resistance is difficult to treat resistance, is broader than carbapenem. And then I'm going to look at the evidence for what we currently have and then new options for treatment. Okay, so just so we're on all the same page, obviously carbapenems, as we're talking about carbapenem resistance, their role is obviously to interfere with cell wall synthesis, and they do this by irreversibly binding to penicillin binding proteins, which are transpeptidases, which inhibit transpeptidation during the cell, disrupting cell wall synthesis, and small holes keep appearing in the cell membrane in the presence of carbapenems, because the cell autolysins are still at work trying to make room for the new peptidoglycans, and so you get osmotic fragility and osmotic shock, and the bacterial cell dies. So again, this is well known to everybody, so I'm not going to dwell, but I mean, apart from the carbapenemases, which we all tend to focus on, there are very important intrinsic and extrinsic resistance mechanisms, particularly through alterations of porin channels, which reduce entry of the carbapenems into the cell, but also efflux, very active efflux pumps, particularly in Acinetobacter and other concerning bacterium, and then there's changes in the penicillin binding protein sites. So these are the real mechanisms of carbapenem resistance we're looking at, and also many of these, of course, porins and drugs and drug efflux also relate to some of the other drugs we'll talk about. Thanks to Adrian for this slide, which basically remind us again, when we are talking about the beta-lactamases, the carbapenemases, we're really talking about serine versus metallo-beta-lactamases. There's two serine classes, class A, which is predominantly KPC, which thankfully at the moment we don't really have much of in South Africa, although we're looking, obviously always looking for, could whoever, Pfizer, could you please turn your, could you please mute?
I can actually do a discharge for her.
Could you please mute whoever is on? Could you please mute? Thank you very much. KPC, obviously we're looking for particularly in travelers. And our main gene resistance genes are the OXA48s, class D serine carbapenemases. But then there's also, of course, earlier penicillinases, cephalosporinases, and ESBLs, which of course also play in to resistance, particularly in very extensively drug-resistant pathogens, and as I'm going to talk about, difficult to treat pathogens are also important. So obviously, internationally, these are critical, the carbapenem-resistant gram-negative bacteria, so much so that they topped the list when we were devising the priority pathogen list for...
Are you very busy?
Sabile Jallo, could you please mute your mic? Sean, I think you are able to mute people. If you could help me, that would be really kind. Thanks very much. So the carbapenem-resistant organisms, Acinetobacter, Pseudomonas, and the CRE, top of the list because there's very few options available, and a real need for drug discovery and research and development, which is what this list was really trying to look to. So just to give you a flavor of what's happening in South Africa, and I'm just using meropenem resistance. Obviously, this doesn't mean total resistance, but it's a marker of carbapenem resistance that I'm using with NICD data from the antibiotic resistance dashboard. And so for this Enterobacteriales organism of great importance in South Africa, about a quarter are meropenem resistant nationally, and relatively similar, slightly more in the private sector, 2021 in red, 2020 in blue. And then obviously that varies very much across the country and in different facilities. And so it ranges in Universitas, relatively low percentages to some slightly higher percentages in some of the hospitals in Gauteng and KZN, and a little bit sort of fairly in between in the Western and Eastern Cape. In terms of Pseudomonas, it's pretty much the same in terms of just carbapenem resistance, about a third to a quarter, but you really start hitting the big differences with Acinetobacter baumannii, as you know, very high carbapenem resistance, around 80% nationally, and little difference between public and private sectors. This is a really difficult bug to treat, particularly because of its really huge number of different resistance mechanisms, which are shown in this graphic. It's not just about enzymes, it's also about modification of the transpeptidase, and also particularly active drug efflux systems in Acinetobacter, which really make it such a difficult bacterium to treat. But although the talk was requested to aim at carbapenem resistance, I think it actually more relates to difficult to treat resistance. And this was defined in 2018 from a US paper in CID, which is shown here, which really looks at the issue that we're currently facing, which is that it's not just about carbapenem resistance, but we're seeing a loss to all first-line bacteria antibiotics. So the definition here of difficult to treat resistance are those bacteria, gram-negative bacteria, that are resistant to all beta-lactams, which includes the beta-lactam inhibitor combinations, plus fluoroquinolones. So in effect, no real first-line treatments. Now, however, some of those, of course, will still be sensitive to the aminoglycosides and to some of the other second and third line drugs, but it really gives an indication of very difficult to treat resistant infections. And you can see the relationship to the CDC definitions of multi-drug and XDR, with overlap, obviously, of these difficult to treat resistant infections between the XDR, PDR, and MDR. And this study by Kadri, they looked at 173 US hospitals, about 30,000 patients, around 45,000 blood cultures, of which 1% were difficult to treat resistant infections by their definition, with a stepwise increase as you go through carbapenem resistance, extended cephalosporin resistance, in other words, ESBL, and then mono resistance with the fluoroquinolones. And the largest number of these bacterial isolates were Acinetobacter baumannii, which by now is of no real surprise. And I think the important thing about this definition of DTR is, as shown in the bottom left-hand corner, this graph shows that there's a 40% mortality in hospital from these organisms, compared to 20% really across the board, irrespective of whether it's just fluoroquinolone monoresistance or ESBL or carbapenem resistance. And as you lose lose your active drugs, on the bottom right, again, you see the shift up to increase mortality. And the risk factors, again, not surprising, Acinetobacter baumannii, but also hospital-acquired infection and prior bloodstream infection in particular were risk factors for difficult to treat organisms. And I think it's important that we survey for these now and we report them, because it gives actually a much better indication of really the problem we're facing than just carbapenem resistance. Chad and Hoa have very kindly helped to compile this. It's just a little snapshot of what's been happening in terms of difficult to treat resistance at Geneesheer, again, with the definition of beta-lactam and fluoroquinolone resistance. And these are numbers both by month and by year of a combination of the Enterobacterales, Pseudomonas, and Acinetobacter. And you can see, although the frequency, the number peaking in 2019 at about 85, 90, don't get fooled by 2020 and 2021, of course, because we have had less nosocomial infections, probably because of COVID. But although the numbers aren't huge, they are reflecting a real problem that is increasing, and one that we have very little armamentarium to deal with. So the first thing I want to really look at is what the evidence is for combination versus monotherapy. And it really speaks mainly to colistin plus carbapenems. But this meta-analysis, systematic review meta-analysis published this year, looked at 134 studies. As you can see from the left-hand graphic, there were a huge number of different combinations, the majority of which did use a polymyxin, and the commonest combination was with carbapenem, but there were I think 92 antibiotic combinations. Now the problem is that the studies that were included were so heterogeneous and lacked the clear definitions and a variety of severe problems which increased the risk of bias to such an extent that the authors were unable to perform quantitative synthesis for any of the endpoints, including mortality and clinical cure. And only 21 of these studies of of 92 combinations adjusted for comorbidities, which we know is so important in outcome. So really, based on this, there is no really systematic evidence to suggest that combination therapy is better than monotherapy. Now, I'm not going to go into the well-rehearsed reasons why monotherapy may be, combination therapy may be better, and why combination therapy may have more collateral damage, because that's well known to everybody. But on the basis of this, I don't see that there's good evidence for combination from this systematic review meta-analysis. Looking more specifically at colistin versus meropenem, this analysis of an open-label randomized trial in carbapenem-resistant gram-negative bacteria from 3 countries in Europe, mainly looking at Acinetobacter baumannii, and mainly looking at sick people with nosocomial pneumonia or bloodstream infection. Again, there was no superiority in combination versus colistin monotherapy. And that was for primary or secondary outcomes, which is shown on your right. And really the Kaplan-Meier shows again that there is no benefit in this analysis of a fair number of patients, to be fair, about 200 in each group, from combination. There was then a meta-analysis systematic review attempted for polymyxin monotherapy or in combination with carbapenems. And you can see from the bias outputs that really there was such huge bias in these studies, it's just not possible. I mean, there were 22 studies, 19 of them were observational, with all the bias that heterogeneity that brings. And really, there was just one RCT which showed for Acinetobacter carbapenem resistance in the bloodstream, polymyxin and rifampicin was of no benefit over polymyxin alone. And really, removing any of the critical risk of bias studies, there was no association. So I don't think that there is good evidence for combination therapy with a meropenem with colistin. Now, the one question that has been asked a number of times is, what about if the meropenem MIC is less than or equal to 8? And this really involves 2 studies, as far as I know, and I'm happy Adrian and others are on the line who can tell me that I'm wrong and help us further with this. But there were 2 studies by Dacos and Tamburello about 5 or 6 years ago. The first in bloodstream infections, showing that if the carbapenem MIC was less than 8, there was an improvement, a benefit in mortality 58% versus greater than 33%. And in the study by Tamburello, you can see the actual graphic, the graph and the numbers themselves, a reduction odds ratio for mortality in this study for meropenem with an MIC of less than 8. Now, again, I think the problem in terms of interpretation rests in the fact that these, although these were bigger studies and they were retrospective observational studies over a number of years in both of the studies, and the numbers were relatively high, they are still potentially biased, and there's no good evidence, randomized controlled trial evidence to suggest that meropenem MICs really make a difference. So I think for directed therapy, and obviously I'm talking about directed therapy, my take on this and my practice is now firmly in the realm of colistin monotherapy. So if colistin is really all we've got, and that's often the case now, we need to optimize our use. And Gary and Esme Visser-Kift in 2014, very nice publication, which I think stood very well, looking at the evidence base and really the critical importance of the loading dose. Just to remember that the colistimethate sodium, the prodrug and colistin are excreted differently. Colistin is non-renally excreted predominantly, whereas the CMS is renally excreted. And it takes, to get to steady state, it takes usually about 4 to 5 half-lives, which is 14 hours for colistin. And there's a real increase in volume of distribution in those that are critically unwell. So a loading dose is really important. And again, this graphic just shows what we know is that a loading dose is critical to get into steady state quicker. And in serious infections and complicated infections, we need that quickly. And so the maintenance dose, the loading dose is based on ideal body weight, either 9 or 12 million units. And the maintenance dose should be given 12 hours later. And with normal renal function, 4.5 million units 12 hourly. The problem is, which makes this drug such a problem, is that with normal renal function, it's actually really difficult to get up to the levels that are needed to, in terms of peak colistin, and to really get into its sweet spot in terms of its PK/PD. And that's really problematic. As far as I know, there's still not commercially available therapeutic drug monitoring, which also makes it problematic. But I think if we are going to use this drug, we really need to do everything we can to ensure it's stewarded properly in terms of optimization. Now, increasingly, we're seeing problems with colistin resistance. And so we're having to bring in other antibiotics that may be less palatable, but may have a role. And I'm just going to look at some of these in the next few slides. So Tigecycline, as you know, its action is to inhibit the elongation of the peptide chain at the 30S ribosomal subunit. Its resistance is predominantly around TET protein mutations, which can now be mobile with these TETx gene variants, but also importantly, overexpression of efflux pumps. The issue with Tigecycline, which has often caused a headache, is that it doesn't seem to stick around in the blood very quickly. Very long, sorry. It distributes very broadly, and particularly into the abdomen, into bile and the gallbladder. And these figures on the right relate to the ratio to serum concentration. So that's why Tigecycline is of use and of great interest in abdominal, complicated intra-abdominal infections. But as you can see, there are some tissues and fluid, such as bone, synovium, CSF, where there's very little penetration. And so not good for prosthetic joint infections, particularly, and others where we're sometimes being forced to use it. The issue again about use is about dosing. The traditional dose is 100 milligram loading dose and 50 milligrams BD thereafter. There have been a couple of attempts to really look at this more carefully. A systematic review and meta-analysis shown at the top by Jean and colleagues a year ago synthesized the data with 9 observational studies, most of whom were in ICU. And unfortunately, again, most of these studies had a serious or critical risk of bias, but the odds ratio for death was reduced at a higher dose. But again, I think one has to be very careful about this because the numbers in that, the numbers in the studies, if you remove the critical bias, come down dramatically. The other study was a comparative phase 2 study between different doses of tigecycline, not the standard dose, but a high dose of 200 and then 100 versus 150 versus and then 75 versus imipenem for the treatment of HAP. And for the higher dose, there was a clinical cure rate at 10 to 21 days of 85% versus 69% for the intermediate dose. And so this both of these suggest that a higher dose, 200 and then 100 BD, if we're going to use tigecycline, is important. Of course, the problem is, as you know, that tigecycline carries with it these FDA black box warning for higher all-cause mortality. So in comparison with other antibacterial drugs for the infections relating to tigecycline, 2.5% all-cause mortality in tigecycline versus 1.8%. And therefore, particularly in the US, FDA guidance is often followed, and tigecycline is not used very much at all. However, in the US, they have alternatives, and we rarely do. There have been some real-world studies particularly from Europe, 5 countries, looking at tigecycline for complicated intra-abdominal infections, both in monotherapy and combination therapy, in fairly good response rates, as you can see in top left. Not a huge difference really in monotherapy versus combination therapy when using tigecycline, nor with community or nosocomial infections. But what it was quite interesting is, and thanks again to Adrian for that bottom right figure, quite good, still good efficacy in patients who are very sick with higher Apache scores and higher SOFA scores. Not quite as good, obviously, as the less sick, but fared fairly well. This was in complicated intra-abdominal infection, complicated skin and soft tissue infection, again, doing quite well even in severe patients with severe disease, clinical outcome at the end of treatment. So another set of drugs that we're being forced to use more and more, particularly in carbapenem resistance, are the aminoglycosides, and amikacin in particular. And again, this is an inhibitor of peptide elongation by binding to the helical site in 16S in the 30S subunit. The problem is that its acidic pH inhibits transport across the cytoplasmic membrane because of the effect of acid on cations. And so in the lung, bronchial tree, biliary tree, and CSF penetrates very poorly. Why does it penetrate into a very acidic environment? Or why does it work well in very acidic urinary environments? Again, I'd be interested to know other people's views and get help here, but I think on balance, it's probably because of the massive concentration of the aminoglycosides into the urine, which overcomes the issue with transmembrane transport. It's also poorly active against biofilms, which make it a problem in prosthetic joint infections. But its killing effect is not only its concentration dependent effect, but also this post-antibiotic effect for hours after the end of the infusion, where there's bactericidal activity. Resistance is mainly through modifying enzymes, but also efflux pumps. And of course, therapeutic drug monitoring is critical, and I think everyone's well aware of that. I'm not going to go into it. One of the reasons I bring it up is because we recently had a case where we had to look at the option of tigecycline and amikacin, the only 2 drugs we had, and I think breakpoints were fairly close to the tigecycline breakpoint. So we looked at this, and this was the only study we could really find, which showed that although synergism rates were quite low in terms of tigecycline and the aminoglycoside, additive effects were fairly high, and the Monte Carlo simulations again favored higher dose Tigecycline 200 and then 100 plus higher dose amikacin over lower dose, and similarly for the gentamicin. It's often put to us about whether nebulized inhaled tobramycin and colistin are of use. I think it depends. I think in hospital-acquired infection, nosocomial hospital-acquired infection and hospital-acquired pneumonia, and ventilator-associated pneumonia, there isn't very good evidence for it at all. As you can see from this systematic review, balanced observational and small randomized controlled trials, mainly in the sort of most worrisome gram negatives. But unfortunately, the meta-analysis was underpowered for the primary outcome, which was clinical cure. And really, very high mostly high heterogeneity, and little can, I think, be taken away from this to recommend it. There was another study after this, which was a randomized trial using both inhaled amikacin and fosfomycin versus placebo, in addition to the intravenous drugs. And there was a suggestion actually that compared to standard of care, it was ineffective in improving outcome. So I think, as opposed to cystic fibrosis with chronic Pseudomonas infections, some of which may be resistant to carbapenems, there is a place particularly for inhaled tobramycin and sometimes colistin, particularly with newer routes of a newer methodology such as nanoparticles and other methods. I think there is a role, but not really for carbapenem resistant or DTR HAP-VAP infections. The other question often comes, should we be trying double carbapenem therapy? And again, help would be welcomed, but I could only really find this evidence for carbapenem KPC producing Klebsiella pneumoniae in this study, where they synthesized eight case reports and 6 clinical studies. There's no really good randomized study at all. And for this specific bacteria, for this specific resistance profile of this carbapenemase, they reported mortality, improvement in mortality using double carbapenem strategy. But again, you need large randomized trials to really show this. But if your back's against the wall, you've got a KPC Klebsiella, it's worth a try. So lastly, moving on to neuroantibiotics and combinations, there's a big list, and this is by no means exhaustive. There are others now certainly coming onto the market or being trialed. Carbapenem-Tenebubactam is one. There are other boron related inhibitors as well. But the ones really that we have been looking at are Ceftazidime-avibactam, ceftolozane tazobactam, and cefidoracol. And we're going to just have a look at these really. So there are real problems, as you know, with assessing these new antibiotics, particularly because most of the trials which led to their approval are non-inferiority trials, and therefore doesn't help us about whether there's superiority. And for us, non-inferiority trials, if it's not inferior, then and it's hellishly expensive, we're going to be using our standard treatment anyway. The other issue is that the testing and the antibiotic susceptibility testing particularly, and the working out of clinical breakpoints really lags behind. So often there's about 12 months or so of time where we don't know whether there's A, risk of treatment failure, and B, potentially driving some of the resistance. It's also exorbitant expenses I'll come on to. So if you're feeling rich and you want Ceftaz-Avi in South Africa, currently 87,000 Rand for a 7-day course for a primary bacteremia. So avibactam is a diazer bicyclooctane beta-lactamase inhibitor. It's active against our main resistance carbapenemase, OXA48, but also against KPC. But Of note, it's not active, obviously against NBLs, but importantly against Acinetobacter or Stenotrophomonas either. And with our large numbers of Acinetobacter, carbapenem-resistant Acinetobacter, we've got a problem there if we want to use Ceftazidime-avibactam. It's approved but used off-label, often for, I think, for bloodstream infections now, but approved for the standard recommendations. And there are lots of non-inferiority trials against various carbapenems showing non-inferiority. The concern is around whether A, it's really superior against carbapenem-resistant bacteremias and carbapenem-resistant bacteria. Again, this really the only study I could find of just over 100 patients, all of them KPCs, so not really in our setting. But the resistance, the KPC bacteremias, higher rates of clinical success than other regimens, very small, difficult to interpret. And a major concern now is the resistance, accrual of resistance mutations, particularly in the BLA-KPC gene, which seems to be driving some of the resistance. And the resistance, there have been a couple of studies, but again, not very big ones. This one from Shields and colleagues about 5 years ago, looking at the emergence on treatment in carbapenem-resistant Enterobacteriales that were all had MICs of less than 1 at the beginning. There was 30% detected Ceftazidime-avibactam resistance with an MIC of greater than 8 at 30 days. Just for interest, and again, this is kindly provided by Chetna Govind, just to look at a single private laboratory, Lancet, in KZN alone, looking at their CRE isolates. Ceftazidime-avibactam started looking at it in 2020, overall percentage susceptible only 61%. And if you're breaking it down into the OXA48s versus combinations, obviously you get a severe drop because of the NDM. But even, and particularly in Serratia, which is very problematic in KZN apparently, 14% resistance. And that, you know, this drug hasn't even been used in public systems really yet, and we're already losing it. So extremely expensive, quick to be lost, and a problem if you've got Acinetobacter. Ceftolozane tazobactam, which is unpriced at the moment, it's not really available here in South Africa. Very stable against AMP-C cephalosporinases, but not active at all against CRE, again, Acinetobacter or Stenotrophomonas. A couple of reports, again, highlighting resistance in carbapenem-resistant Pseudomonas aeruginosa. But it definitely, this drug is definitely an excellent drug in Pseudomonas infections in particular. It has very robust activity, but again, I'm concerned that with transmission or carriage of resistant Pseudomonas into the country at some stage, even if we get hold of it, we're going to have problems. Lastly, if you're feeling really rich and as a nice present for somebody, 110,000 Rand for a 7-day course of fludarabine. It's a really interesting new siderophore cephalosporin, which is interesting because, for 2 reasons. One is because it circumvents porin mutations by gaining access into the cell through Trojan horse mechanism using ion transport systems, which then dissociates and allows the cefidrochol to bind and act on cell wall synthesis. And the other interesting thing is that it has a really wide spectrum of activity. So it's active against not only the class A KPCs, our class D OXA48s, but it also has activity against metallobutyllactamase class B enzymes. So is it the new great hope? Well, there were 2 studies published in the Lancet this year. Again, probably well known to people, both nosocomial infections, the APEX, NP and nosocomial pneumonia trial, phase 3 trial, sick patients mostly in ICU against the comparator of meropenem at extended infusions at high dose. And no other gram negatives were allowed that could confound things. The endpoint, primary endpoint, as you can see, was mortality at all cause at 14 days. And it was non-inferior, which really just tells us that it's non-inferior to our current best that we've got, probably, which is extended infusion high-dose meropenem with an adjusted odds ratio, as I said, which was less than the upper boundary of the 12.5 set for non-inferiority. And there was no difference in if the meropenem MIC was greater than 8. In the credible CR study, this was not just nosocomial pneumonias, but a third were bloodstream infections. It was cefidoracol against best available, but most of those were colistin. Similar endpoint, primary endpoint, clinical cure. Some strange results in endpoint mortality seemed cefidoracol high mortality in HAP, VAP, and BSI versus complicated urinary tract infection, where it was lesser mortality. The problem was that these were predominantly Acinetobacter baumannii, a very high mortality in each group. And so I think it's, again, quite difficult to really make a pronouncement on this more than just to say that I think it shows at the moment that cefidoracol, is pretty much as good as the comparators that we've got. But high mortality in carbapenem-resistant Acinetobacter baumannii from the credible CR study, I think, should be a word of caution when we do start using it, if you want to start using it for Acinetobacter multiple drug resistance. Lastly, I think if you got difficult to treat metallo-beta-lactamase infections, there are these sort of 4 main options. I just want to touch on Ceftazidime-avibactam. There's also now in development and in trials as Ceftazidime-avibactam as well. And this was a study in an observational study in Enterobacterales, predominantly Klebsiella, pneumonia, and predominantly NDM, with about I think only 16% or 20% were VIM. Small number, 100 patients, not bad, but mainly with bloodstream infections, and it suggested a survival benefit with Ceftaz-avi plus aztreonam over the other available active antibiotics. So I think, again, backs to the wall, if you had Ceftaz-avi or just avibactam aztreonam, or Ceftaz-avibactam aztreonam, is probably as good as you get if you can't use colistin mono or combination therapy. So in wrapping up, I just want to thank Adrian, who provided some of the images for the slides, Chad and Hoa for the work on just some of the data on the DTR at Retrospective. Sorry, Chetna Govin should be there. Apologies, Chetna, for her KZN data, and Varney and Mark for some of the discussions about pricing. So in conclusion, I mean, I think unfortunately we're up my favorite Netflix sitcom. Unfortunately, we're facing an increasing number of difficult to treat resistant gram-negative bacteria. We all are seeing this daily. I've really focused on, obviously, these discussions on mainly on bloodstream infections, but we're seeing them all over, and we need to look at our data carefully. Personally, I sort of firmly believe that there's very little evidence for colistin combination therapy in these difficult infections when you can use colistin. It is important that we optimize how we're using these drugs. I don't think there's much evidence outside of cystic fibrosis for nebulized antibiotics. Unfortunately, although there are some new toys, we're currently unavailable, and as usual, we're unable to play with them. So with that, I'm going to stop there and come back to invite any questions or comments. I'd be very interested to hear any views. If you do have any questions, if you could either raise your hand or if you haven't, so Sean.
Thanks very much. Really comprehensive, really nice, helpful talk. So you spoke about these isolates with lowish under 8 meropenem MICs. But what about isolates with even lower MICs, so like around 2 or even in the susceptible range with carbapenemases? How do you feel about using meropenem at kind of optimized dosing, so to avoid colistin for those infections? Yeah,
so I probably should have gone into it, but I didn't. I mean, I think the issue, as we talk about quite often, Sean, is relates to perhaps which carbapenemase and which profile you're looking at and what the mechanism is. If it's an OXA48, meropenem seems to do pretty well against the OXA48. So I think if the meropenem MIC is 4 or less, I would be happy to go with high dose extended infusion meropenem with 2 grams, and we do that quite a lot. I think if you've got something more worrisome, and we haven't had a KPC, but I'm not sure even with KPC whether the enzyme is quite so forgiving. But again, maybe Adrian or one of the other experts can give some ideas about that. Adrian, what are your thoughts? You have your hand up. Could we see your lovely face? There we are.
I think patients can respond to, particularly to OXA48, if the MIC is less than 8. So I agree with that. I just wanted to make one more comment, which I wasn't aware of until recently, that polymyxin B is available in South Africa. And there is evidence based on, I think about a year or 2 ago versus colistin, that it's got a slightly better pharmacokinetic profile. It's not a pro-drug. I'm not sure if therapeutic drug monitoring is available. It's inexpensive, and it has got a slight advantage from a toxicity point of view. So I think what we need to do is so I've asked Warren Lohman to provide me with more detail, and one should probably, with you and the team, sit down and think if we shouldn't perhaps try and procure polymyxin, if there's any advantage to it, if the dosing is easier, the pharmacokinetics and so on. Try and, yeah, that's about it. Thanks, Bob.
No, thanks. And yeah, I think you're right. I mean, when I last looked at it, it certainly had better distribution into a number of the tissues and body sites. I mean, the colistin is, I think, better for urinary tract infection, where the focus is urinary tract over polymyxin. But yeah, I think that's very exciting. That's great. Chad, I wondered if you'd comment on, when we were looking at the difficult to treat resistant infections, one of the questions is, what the level of resistance to the aminoglycosides in the American study, they, of all of theirs, 33%, so a third, were resistant to all aminoglycosides as well, which obviously puts in another layer of complexity. So, I mean, Chad, would you comment on our data?
Sure. So, I mean, if we're looking overall at all the difficult to treat organisms, so that would be the Enterobacterales, Pseudomonas, and amikacin combined. I mean, and Acinetobacter baumannii combined. It ranges from, and this is for susceptibility, between 20 and 50%. So there is retention of susceptibility in quite a number of cases. In addition, for Acinetobacter, we also test tobramycin, and that we did see quite high susceptibility rates in 2016, 2017, but that started to drop down to 12%. So, initially Acinetobacters retain susceptibility to the aminoglycosides, especially tobramycin, but we're losing that. And there's the occasional isolate that's actually retains susceptibility to gentamicin as well. We also get the occasional CRE where cotrimoxazole is an option, but that's quite a that's 5 to 7%.
Great. No, thanks very much. No, that's great, Shan. Thanks, and thanks again for the data. I'd like to ask Helen van der Plas, who's in private, and then Brian Ely, if you'd comment from the sort of pediatric side what you're seeing. Helen, you've got more access to lovely toys. What's your experience with Ceftazidime in particular?
Hi, Mark. I'm going to start off with ceftazidime. What is it? Ceftazidime-avibactam.
Ceftazidime-avibactam.
Tazobactam. Sorry, Mark.
Okay.
Sorry, a little bit unprepared. I remember 2-3 years ago, we had a gentleman with a pan-resistant Pseudomonas. Complicated skin structure infection. Actually, he was involved in a bomb accident, and his whole hind quarter was blown away, and that obviously multiple surgical reconstructions and so on. And not surprisingly, eventually we had the Pseudomonas that we had to deal with, and it worked beautifully at a huge price and huge cost. And to this date, I don't know yet, as you mentioned, you don't know how much it costs. I don't know how the pharmacy recuperated its cost. I don't know what it was billed at. So it's the only time we've used that, and there was a need for that, and it worked. It was an exceptional case. My biggest bugbears, we have, unfortunately in our hospital, we are a referral unit for all the other, and a receptacle for all the other ICUs in the Western Cape because of our rehab unit. So that makes our institution so vulnerable. So we have a CRE, cesspit, swamp in our rehab unit. I'm sorry, if anybody from Night Healthcare is listening, they probably want to fire me now, but and that's our vulnerability, because the patients come across to us and they're all colonized with CREs. And first it was only OXA48, and it's now OXA48 and NDM. And that equals, but they're resistant. We've lost colistin as well, or polymyxin. We're going to now also try and get polymyxin B. It's just, we're just going to stock that now going forward. And we sometimes, so we use a combination. Of course, we use in the ICUs, we use extended infusions of carbapenems with colistin, and we saw a lot of CREs with our COVID ICUs. They were using a combination of colistin, amikacin, and extended use carbapenems. A lot of our carbapenem MICs are above 32. And the saddest thing, and if I can just have microbiologists listen to this, we have microbiologists in the private setting that recommend using Ceftaz-Avi in patients in our rehab unit with urinary tract infections or skin and skin structure infections from their pressure sores and what have you, where they culture OXA48s and Carbapenem-Resistant Klebsiella pneumonias. That's our pet, our resident organism here. And they recommend Ceftaz-Avibactam, and they're medical officers that have been prescribing this and sending this to our pharmacy. I mean, that was just outrageous, and I luckily with our pharmacy team were intervening. And unfortunately, we hear this a lot, where Ceftaz-Avibactam is being abused and used in the private ICUs, and it's just frightening, and it's not controlled. and somehow this needs to be controlled. But I don't know, there's no legislation, it's a free for all. And that's so scary. It really is. And as you saw, those carbapenem resistant gram negatives, you've shown the data there. It's really scary. Yeah. Thanks.
No, thanks, and thanks for answering, even on the spot. It's wonderful. Ryan, have you anything to help us understand in the pediatrics? Is it the same?
I don't have much to add. I think many of our CREs are still sensitive to colistin, and we have used it. I think we have combined it on occasion with carbapenem, the colistin with carbapenem, but I agree with you that we should probably revert to colistin monotherapy. We've had one recent case of serratia that we treated with, what did we treat it with? Ceftazidime-avibactam, and we succeeded to clear that infection. We're just about to start a study, one of my registrars, to look at our CRE systematically and to see whether we can find anything in addition to what we've observed in clinical practice about our CRE infections. So I think we will get some information about that in about a year's time.